Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Now, in this chapter, we're going to explore anxiety, obsessive-compulsive, and trauma, stress-related disorders. Now, this topic, like we'll see with the remaining disorders, will be in 3 parts. In part 1, we're going to review the variety of types of anxiety-based disorders, sort of a description. In part 2, we're going to look at the theoretical perspectives and how these disorders come about. And then lastly, in part 3, we'll consider the treatment options for each category of the disorder. So, to begin this chapter, we can start with a definition of anxiety. Now, it's important to remember that with every category that we'll look at, we might be able to say, that sounds like me, or I do that sometimes. And we need to keep in mind that the 6 criteria we talked about in Chapter 1 about determining abnormality, and we also need to remember, don't self-diagnose, because the conditions within the DSM-5, in terms of what would sort of fit a diagnosis, requires not just the odd experience from time to time over the course of a year, but continuous and regular. And oftentimes, it's not something that people will acknowledge and say to others because they don't feel like that anybody will really understand it. So let's go with anxiety in terms of, well, what is anxiety? It's a generalized sense of apprehension or fear. Now, some of this is normal, and desirable under certain circumstances to have anxiety and fear, but it becomes abnormal when it's excessive or inappropriate. Anxiety may be experienced with a range of physical features, conditions, and behaviors. Some of the physical features, this includes jumpiness, jitters, increased perspiration and heart rate, shortness of breath, dizziness, and nausea. Some of the cognitive features, and those are the physical features, some of the cognitive features will include excessive and prolonged worrying, overly aware of our bodily sensations, jumbled thoughts and nagging thoughts, the ones that just never seem to leave you. Now, some of the behavioral features, they're going to include the need to escape or avoid the situation, agitation, clinginess, need for reassurance. Now, it's important to note that these descriptors are not, again, they're all on this sort of continuum between these are normal and sort of what you'd expect under these sort of circumstances, but they pass to in the middle where they may be problematic, but they're not interfering with everything in your life. And then, of course, there's the others, the ones that are considered concerns. So disorders involving anxiety are historically classified as neuroses, which were originally believed to be organic in nature. Now, psychodynamic theory posited that the origins of neurosis lay in psychological factors, that neuroses reflected a threat of the consciousness, of threat to the conscious emergence and the repression of unacceptable impulses. And that conflict between, our conscious awareness and unacceptable impulses were the root of where psychodynamics theories were looking at. So Freud, he believed that different kinds of neuroses reflected different ways in which the ego defended itself from anxiety. This etiological hypothesis, so this is in this sort of form of disorder as neurosis. Now, neurosis has been used in the DSM since 1980, but instead they consider observable behaviors rather than what is considered the observable. Neurosis has been used in the DSM-5 since 1980. Instead, they consider observable behavior rather than causation assumptions. The DSM-5, it considers dimensions of disorders. So anxiety disorder, panic disorder, specific phobia, social anxiety disorder, and generalized anxiety disorder are the dimensions the DSM-5 recognizes. So we're going to start with a disorder known as panic disorder. And this is the first form of anxiety disorder we're going to look at. Now you can see there's a table in your textbook which looks at the criteria. Now panic disorder refers to recurrent unexpected panic attacks. That's criteria A. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, during which time 4 or 5 of the list of the 13 in table 3.2 physical and cognitive symptoms will occur. Now it's important here. Many of you might say you've had a panic attack, and yet you need to keep in mind, that this is an abrupt surge of intense fear and discomfort to the point where you won't remain where you are. You will exit ASAP. That's the behavioral component. As quickly and as easily as you can. The worries about panic attacks and their consequences usually pertain to physical concerns, such as worry that panic attacks is going to reflect the presence of life-threatening illnesses. Social concerns such as the embarrassment or fear of being judged negatively by others because of visible panic symptoms. And concerns about mental functioning such as you're going crazy or you're losing control. But this is all under the criteria B. And so these are real concerns for people, and it's something that makes it difficult for those of us who don't experience it to get a handle on. Now there are 2 exclusion criteria for panic disorders. The disorder cannot be due to substance abuse, drugs, or medication. That's an important exclusion. Okay, and or medical condition. And the disorder cannot be explained by comorbid disorder. Now, what is meant by comorbid is that another disorder that you may experience or have or be diagnosed with influences the similar conditions of what is a panic attack. If there's another reason to explain the panic attack, then it gets excluded, and that's what comorbid means. Now, panic disorder is often comorbid with other disorders, namely agoraphobia, fear of being in open spaces. About 1/3 to a half of people with panic disorder also have agoraphobia. And the majority of people with agoraphobia have a history of panic attacks. So there's a relationship between those two, and a person wouldn't be diagnosed with panic attacks if they were already diagnosed with agoraphobia. Okay. Now in the DSM-5, agoraphobia is a distinct disorder involving a fear, concerns, anticipatory anxiety, or excessive worry about being in open spaces, closed spaces, using public transportation, standing in line, being in crowds, and in general any place outside the home environment. So as you can only imagine, people with agoraphobia don't get out much. And it's that fear that inhibits them. What might happen if I do, and what happens in those circumstances. So agoraphobia is diagnosed separately from a panic disorder. If both exist, 2 diagnoses are given. Now, a second category or dimension underneath anxiety disorders is generalized anxiety disorder, GAD. And it's characterized by persistent feelings of anxiety that are not triggered by anything specific, not a specific object or a specific situation or a specific activity, but rather seem to be what Freud labeled as free-floating. People with GAD are chronic worriers. Now, you have to look at the word chronic in the same way that you would at chronic in terms of a physical ailment, chronic back problems, chronic, some other physical condition. Chronic means long-term and regularly occurring as opposed to acute, which would be short-term and painful, but it disappears. Chronic worrying is accompanied by general feelings of dread, foreboding, and heightened states of sympathetic arousal. These are the things that you don't control, but your body starts to get very aroused and alert. Now, a third version is what's known as, of anxiety disorders, that is, phobic disorders involving phobias. Now, these are the excessive phobias that are excessive irrational fears of specific objects or situations. Phobias involve a behavioral component, avoidance of phobic stimuli, so whatever that situation or event or object is, and a complete get away from, so complete avoidance of the physical stimuli in addition to the physical and cognitive features. The reactions you get. If you have a fear of spiders, for example, it's not that you want to just run away from it, but you have a physical response and you have some cognitive or thinking, oh my God, it's going to, bite me and I will die. So specific phobias are excessive fears of a particular object or a particular situation. Now, there are 5 forms or types of phobias. 1, there's the animal type, so spiders, snakes, and dogs, for example. 2, natural environmental type, so this would be things to do with how high up you are off the ground. Storms, water could be parts of your fears or phobias. 3, blood injection type, blood injection injury type, so seeing blood or receiving an injection is another class of phobias. 4, situational type, elevators, on planes. And then 5 would be the other type. So these are phobias of things like being choked or contracting an illness or disease, a fear of clowns. These would fall under the other type. So what you're getting a handle on here is I'm just doing descriptions of each dimension. In the next video will be some of the causes for these same disorders, and then the third video will be on the kind of treatments. So the 4th, social anxiety disorder, this involves an intense fear of being judged negatively by others. It is normal to feel uncomfortable or nervous on the first date or in social gatherings or to make presentations in front of the class. That's normal to be anxious. But you can manage to get through it, and you might be wishing you had been able to do it better, or you could have been less error prone. With social anxiety disorder, this is an intense, almost paralyzing experience. Again, this is to meet the criteria for what is abnormal behavior. Okay? Most people might say, I must have social anxiety disorder because I don't like getting in front of the class. That's not the same. Many people who experience social anxiety, it's not just these single sort of events, but it's so paralyzing you may not even leave the house. You may miss class and that experience, or you may miss doing something for fear of being judged, and that's overwhelming. Okay, so what we're looking at are these different dimensions. Now, one of the other dimensions that often gets misunderstood is obsessive compulsive and related disorders. And we're going to begin in this one with the obsessive compulsive disorder, OCD. Now, this disorder involves reoccurrent patterns of obsessions, compulsions, or a combination of the two. Now, people with OCD can be preoccupied with obsessions and or a compulsion several hours a day and experience significant distress. They're not happy about it. They can't not do it, but they're not happy about it. It messes with their normal functioning and routines of their day. Now, obsessions, these are intrusive. You don't ask for them, they just occur. Persistent, they keep coming. Thoughts or urges that create anxiety and seem beyond the person's ability to control. Now, I've taught this course a lot, and I'm familiar with people that I've worked with OCD as a condition. And I can only guess and imagine of the kind of effect that it has on your everyday existence to go through and experience those intrusive obsessions that you may even know are irrational, but the fear associated with not doing them and the consequences of not doing them are profound. So they can include such things as checking and rechecking doors, windows. Are they locked? Or excessive concern with germs and touching people, or things where germs may be transferred. May be transferred. Compulsion, now as an alternative, compulsion as the pairing with obsession, these are irresistible, repetitious urges to perform certain behaviors, such as repeated, elaborate washing routines after using the bathroom, or mental acts of praying, repeating certain phrases, etc. Compulsions are not fun and are not lightweight. They are things that one is uncontrollably driven to do. A person who experiences OCD can at times see the irrationality of what it is that they're obsessed about, or the rituals that they may engage with. However, without treatment, they're going to continue. This is why I will correct people who say, "Oh, my OCD is kicking in." Was someone who genuinely is diagnosed with OCD knows that it doesn't just kick in once in a while. It is constant and debilitating. Now, what I've done is, in your journal that you'll do in week 3, I've posted a video of Howie Mandel, who has OCD, and he talks about what his experience is like. And you might get a slightly different view of what OCD is when you hear him speak. Now, trauma and stress-related disorder comes in 2 primary forms: adjustment disorders and acute post-traumatic stress disorders. And we're going to look at these individually as well. So adjustment disorders are among the mildest, if you want to label things as mild and extreme, but one of the mildest psychological disorders. An adjustment disorder is a maladaptive reaction to an identified stressor that develops within a few months of the onset of the stressor. The maladaptive reaction is characterized by significant impairment in your social world, occupational world, or academic functioning, or by states of emotional distress that exceed those normally induced by a stressor. If you check on table 3.8, you'll see the sort of conditions associated with it. Now, as with most of these disorders, one of the criteria including length of time that the person experiences the effects, and not the 1 or 2 times over the course of a month, but the often and over the length of period of time kinds of conditions. The reaction may be resolved if the stressor is removed, or the individual learns to adapt to it successfully. However, it does interfere, although mildly, compared to some others. Now, an acute post-traumatic stress disorder, PTSD, as you might be familiar with, people develop stress reactions that follow exposure to traumatic events. Acute stress disorder occurs in the days and the weeks following exposure to traumatic events. Post-traumatic stress disorder persists for months, even years, or decades after the traumatic experience, and may not begin until months or years after that event. Now, features of the PTSD reaction include extreme anxiety or disassociation. Now, disassociation just means the feelings of detachment from oneself or one's environment. Intrusive memories and flashbacks, heightened arousal and vigilance, difficulty concentrating. Now, flashbacks would be almost like daydreams of things coming back of the trauma that come into your consciousness, bang, right there. Or you've been walking down the street, maybe you were a war veteran, and a car backfires, and that sound triggers a flashback to bombs going off near you and the anxiety and the heightened fear that you experienced at that time. There's a Canadian, Romeo Dallaire. He was the former head of the doomed United Nations peacekeeping mission in Rwanda, and was discharged from the military for PTSD a few years after the 1994 mission, in which he and his forces tried in vain to stop the slaughter of some 800,000 to 1 million Tutsis and moderate Hutus. he was witness to hideous crimes against humanity, as were many of the members of the military at that time. Genocide, as had many civilians. Dalliard suffered from PTSD in 2000, attempted suicide by combining alcohol with his antidepressant medication, a near-fatal combination which left him comatose. He has gone on to become a Canadian senator since 2005, and his biography made it into a movie called Shake Hands with the Devil. Now, that's just being used all just as an example of the profound impact many of these psychological disorders will have. They're not lightweight, and they don't just sort of come and go on a daily or weekly or monthly basis. They are profound, consistent, and reoccurring. All right, so this is the first part. This has strictly been based on doing an overview of the descriptors. All right, everybody. Part 2 will be looking at theoretical perspectives of what is the cause of anxiety disorders.